Good evening, everybody. I would first, at the outset, like to thank OGP, Sujit sir and Swapnil sir for giving me this opportunity to share some thoughts of mine with you. I'm down with a bad viral, so if I croak like a toad, please pardon. This is not, the most interesting time to have a session because we've gone through some really, really interesting sessions and slumber tends to set in. So I would like to keep my talk, giving a different horizon to it. I would share some cases at the end. Chairpersons, if you can kindly notify me at around 20 minutes so that I can pace my talk accordingly. I always like to speak on lung cancer because lung cancer stands out as a prototype of what change molecular testing and biomarker testing can do to, the paradigm of cancer. From survivals which ranged in few months to a time when 5-year survival is not very uncommon to see in lung cancers. This is the era of, targeted therapy and precision medicine. And as we move forward, I'm sure, this is only going to stay and better with time. So without much ado, so as we know, lung cancers remain as the leading cause of cancer-related deaths in most countries. So, most but not all lung cancers are associated, as we know, with a well-known carcinogen, which is tobacco smoking. The difference is that squamous cell carcinomas are usually associated with high tar content smoking additives, whereas adenocarcinomas are associated with low to moderate tar content additives. What is very important to know that in lung cancers, we don't yet have something which stands out as a very good screening test. Thus, most of these cases are detected, in late stages. With that, what do we do as pathologists whenever we get a biopsy? So what we get are usually CT-guided core biopsies. And a good way to go about these CT-guided core biopsies is probably divide these cores into 2 blocks. While one block can, process immediately for histopathological and IHC evaluation, the other block you can start at the same instance with your biomarker testing. This, as we know in lung, usually tissue is the issue. So this saves tissue depletion and it usually also saves time. I will not go into details of, too much pathology, but I'll just touch these points. As we know that lung cancer is broadly divided into non-small cell and small cell cancers. In non-small cell categories, we have squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. What is the importance of histopathology in an era of biomarker testing? You see, histopathology is still the first point of reference which tells us what biomarker this particular case would be requiring. EGFR, ALK, ROS, RET, MET in lung cancers are still pretty much associated with adenocarcinomas, whereas in squamous cell carcinomas, we generally go for immune checkpoint inhibitors, and that's why PD-L1 testing is the most definitive biomarker testing that is done. There are different IHCs that we use for lung cancers, while TTF1 and napsin are specific for adenocarcinomas. We have P40, P63, CK5-6 for squamous, and we have the neuroendocrine markers like synapto, chromo, CD56, and INSM1 for neuroendocrine tumors. Sometimes we encounter cases in which all markers are negative, and these show the null cell immunophenotype. So broadly, when we talk about adenocarcinomas, morphologically, they are divided into 5 subtypes: lipidic, acinar, papillary, micropapillary, and solid adenocarcinomas. It's important to know these subtypes and document them in your reports because these subtypes have different prognosis. Solid adenocarcinomas are most commonly confused with squamous cell carcinomas, non-keratinizing ones. So these are the ones in which we most frequently put our immunos. Similarly, squamous cell carcinomas are also divided into 3 types: the keratinizing variant, the non-keratinizing variant, and the basaloid squamous cell carcinomas, which we say if the basaloid component is more than 50%. This is a picture to show all the 3 types: the keratinizing, the non-keratinizing, and the basaloid. So with that, let us start our journey of biomarker testing. The first tyrosine kinase inhibitors in lung cancer were used in the first decade of 21st century. These were geftinib and erlotinib. History always tells, it's not just interesting to know, but it also tells us how we've progressed from those times to current. It will be interesting for you to know that crizotinib was initially developed as a MET inhibitor, and activity later towards ALK kinase inhibitors led to its use in ALK activating translocations. We all know, what EGFR has played as a role for adenocarcinomas and how immune checkpoint inhibitors stand out for those, especially the squamous cell carcinoma subtypes. So Broadly, whenever we see adenocarcinomas and squamous cell carcinomas, most of the tumors even today, the mutations are unknown that we encounter. There is a minor variation between what we see in the West versus what we see in Indian population. In Indian population in adenocarcinomas, we usually encounter EGFR mutations, whereas in the West, KRAS mutations are the most common. There are many, many targets for squamous cell carcinomas that which are under study, but we still now don't really have a very potent, actionable, targetable treatment for squamous cell carcinomas. Many a times in clinical practice, you will find debates because sometimes we encounter EGFR mutations in squamous. So what do you do? It's still a debate whether you should give TKIs, you should not give TKIs. There are studies, which are saying FGFR1 can be targeted, but I will show you in my subsequent slides, the importance of each of these. As I told you, smoking is associated with many but not all cancer subtypes. So there is a predilection of smokers towards certain mutations as well. While KRAS mutations are seen mostly in smokers, EGFR, ALK, ROS and RET mutations are usually seen where we suspect oncogenic driver mutations. These patients are younger and they are usually non-smokers or less smokers. As I told you earlier, Asians usually show a high frequency of EGFR mutations. The two major EGFR mutations we see are the in-frame deletions of exon 19. These show better response, and the L858R substitutions in exon 21, which are usually seen in the elderly. So you see, it's important to know in EGFR mutations also what kind of mutation are we talking about, because the response differs. There are other rare mutations that we encounter, and whenever a patient progresses on your first generation TKIs, you should definitely test for alternating pathways of resistance, which would first of all include your T790M mutations and then the other pathways. Now, ALK and ROS1 translocations occur in about 5 to 8% and 1 to 2% of non-squamous NSCLCs. In contrast to EGFR, there is a significant diversity of secondary mutations in ALK and ROS1. The good thing is that for ALK, IHC is a very good modality of testing, but for ROS, we must, the positive cases should definitely go for correlation with FISH. Another very important target is BRAF, which is the easiest to test as all druggable mutations fall on the same hotspot, which is BRAF V600E exon 15. This is seen in 1 to 2% adenocarcinomas. We usually combine agents because single agent can result in rapid resistance. The other mutations that we commonly encounter are the MET and RET. In MET, you can see copy number variations, you can see point mutations, but the most targetable and pertinent mutations are the MET exon 14 skipping mutations. The drugs used in these cases are crizotinib, capmatinib, and teptotinib. Now, the important point to remember, from the clinico-pathological purview is that these mutations are usually seen in patients who are more than 70 years old. So, and these patients, you can't use your broad spectrum chemotherapeutic agents very well. They don't tolerate cytotoxic therapy. So whenever you have a 70-year plus patient, and if the tissue is limited, you should first probably, go for a MET testing. One of the newer kids on the block is NTRK, in which we have fusions for NTRK 1, 2, and 3. These can be tested through IHC, PCRs, NGS. IHC is a good screening tool if it's available. And of course, this can be a part of a broad spectrum panel. So with, this basic idea, the question that comes to our mind is that, there are so many modalities of testing which are available. How do we go about deciding which modality or which platform should we use? So you see, whenever a sample is of high volume, any damn method will, give us the result. But the problem is, as I told you, tissue is the issue with lung cancer. So if you have limited tumor content, you need something that amplifies your tumor, and thus, these kind of testings are much more preferred. If the mutation type is known, you can use a targeted method like PCR. If the mutation type is unknown, a broad spectrum NGS would be a good way to go. There are certain newer, targets which are being evaluated. For example, the KRAS G12C mutations, in which sotorasib is a drug that FDA has approved. Another are the HER2 mutant advanced lung adenocarcinomas after platinum chemotherapy, in which pyrotinib is being deeply studied. And a very new mutation, which is not a part of most of the panels that we see across different diagnostic platforms, is the KEAP1 driver lung cancer progression through the KEAP1 NRF2 activation pathway. Now you see, this is important because this is seen in a majority of squamous cell carcinoma patients, wherein we don't have quite a lot of druggable targets till now. I will not go into the details of this, But with that, let us talk about, PDL1. As we know, PDL1 is, a part of our companion diagnostic test. There are different clones available. There is the SP263 clone, SP142 clone, and DACO22C3 clone. Preferably, these clones should be tested on that same platform, and they have very specific antibodies which are given for pembrolizumab. That's why we use DACO22C3. Certain pertinent points to note is that whenever you're evaluating for lung, lung is special because we give the TPS score, as inflammatory cells in a lung tumor are pretty less, and studies have said that TPS score correlates better with the overall survival. Also, you should always be careful that you don't include necrotic areas in your counting, because they can stain very strongly for PDL1. So this is a broad chart, which tells you what all are the broad spectrum mutations which we test, and their different antibodies which are available. This is the same thing. There is a panel that we do in SRL which covers all these targets with showing DNA and RNA variation. With that, let me just touch upon the advent of liquid biopsies. Now you see in lung, especially when a patient has there's a recurrence of lung tumor, it's very difficult to get a repeated CT guided biopsy. Also, tumor heterogeneity is always a problem. So liquid biopsies, that, these detect the circulating tumor cells which are there in the blood. And it's much more compliant in cases of recurrence, because CT guided biopsies can be difficult. Also, these can capture tumor heterogeneity very well. These are non-invasive tests, so, again, the compliance is much, much better. We have a FDA approved EGFR true liquid biopsy test at SRL that we do, and it detects 42 mutations in exon 18, 19, 20, and 21. But with every good technique, it's important to also note what are the limitations. You see, patients with early stage disease may not have sufficient circulating tumor DNAs in the blood. Presence of normal genomic DNA hinders with the use in early stage disease. Also, while sensitivity of ctDNA, is lower, although the specificity is there. And plus, to get very clear cutoffs, we still need very broad spectrum validations across different platforms and across different laboratories. So this is just, in a nutshell, from your histological testing to your molecular biomarker testing to your PDL1 testing, how we go about the management of lung cancer in the era of biomarker testing. A very important point to note from the clinical pathological perspective is, whenever you are sending a broad spectrum test for lung cancer panel, please remember your NGS report will take a while to come, but your PDL1 will be available much before. So wait for your NGS report to come before starting your immunotherapy. Again, in a nutshell, if there's a squamous cell carcinoma, we go for PDL1 testing. In non-squamous cell carcinomas, if NGS is available, cost is not a factor, you go for targeted NGS for all actionable mutations. If cost is a factor, even in a tertiary care center like ours, we many a times get testing requisitions for EGFR, ALK, ROS1 separately, along with RET, MET, and PDL1. So with that, let us jerk ourselves a little, jolt ourselves a little, and get to some interesting cases. My first case that I would like to present is a 59-year-old male who presented to us with pain in the chest and difficulty in breathing since 3 months. There were a few episodes of hemopsis. Radiologically, there was a lung mass 4 into 3 centimeters with multiple pleural-based nodules. This was reported with the primary center as metastatic adenocarcinoma, likely of colorectal origin. There was no lesion on colonoscopy or upper GI endoscopy, and we got the case, the blocks for second opinion. So when I asked for the PET findings, it correlated with what was told. There is a mass, about 42 into 34 mm, with which is FDG avid, and there is diffuse thickening with nodularity along costal, mediastinal, and diaphragmatic surface. What we saw on histopathology was this. Now, I wouldn't blame anybody who would say that, this looks like metastatic colorectal adenocarcinoma. A lot of mucin, a lot of dirty necrosis. But as we know that we are, in the era of IHCs, and there have been discrepancies, nothing was found on radiology. So you can see there's a lot of intracellular mucin, looks pretty much like a colorectal gland here. But when we threw in the IHCs, we saw that these were positive for CK7 and CK20. 20 is not something you usually expect in your lung adenocarcinomas. Again, the lung adenocarcinoma specific markers like TTF1 and napsin stained negative. Okay? Of course, because there was a colorectal adenocarcinoma diagnosis given, I had to do a CDX2 and a SAT-B2. While CDX2 stained positive, SAT-B2 was negative. So what do you think is the diagnosis here? Anyone? Sorry? Right. So that is a possibility, but nothing was found objectively on endoscopy. So that is exactly what my diagnosis was. I gave a diagnosis of pulmonary enteric adenocarcinomas. These show just the immunophenotype that we saw. These are usually positive for CDX2 and these are negative for SAT-B2. When we tested these for the molecular profile, we saw mutations in HER2, KRAS and BRAF, and EGFR was wild type, again, which correlates very well with this subtype of pulmonary enteric adenocarcinomas. Coming to my next case, case number 2 was a 52-year-old female, 6 into 4 centimeters right-sided lung mass, reported as poorly differentiated malignant neoplasm, and representative blocks were sent for second opinion. So when you see this, like one would really find it difficult to say whether this is a carcinoma or a sarcoma or something else. So this was definitely poorly differentiated. What we saw were some really large cells. Some of them were multinucleated giant cells, and some of them were spindly. So then we decided to throw in the markers. This did definitely guide me towards one particular type of histology. And CK7 was positive, more in the epithelial looking components. Vimentin was diffusely positive. TTF1 was again staining. You can see some of the large cells, bizarre nuclear forms also staining positive for TTF1. So, there was this epithelioid component which was positive for CK7, TTF1 and Vimentin. The stromal component was diffusely positive for Vimentin, focally here and there for CK7. CK20, SMA, Desmin, 5'6", 40, 45 and CD30 were negative. So, any guesses with the diagnosis here? Multinucleated giant cells, spindly forms, maybe, a dual morphology. Sarcomatoid, somebody said? Yeah, so this was finally called as pleomorphic carcinoma. Pleomorphic carcinomas can show you giant cell type, they can show you spindle cell type. And this is a very, very typical morphology and IHC pattern which was there. On mutation testing, KRAS mutation was detected. And very interesting to note that these tumors show you a very high PDL1. TPS score was more than 50% and the patient was responded very well to immunotherapy. This is just to show you a comprehensive molecular profiling of pulmonary pleomorphic carcinoma. As you can see in the paper, most of these, show about 27% of these show KRAS mutations, followed by EGFR and MET mutations, and many of these show extremely high expression for PDL1. Case number 3 was an 18-year-old male patient. On chest radiography, there was a mass shadow 8 centimeters in diameter in the left lower lung involving the pleura. HRCT showed well-defined lobulated solid tumor mass, about 6 into 4 into 7 centimeters in size. This is how the morphology was. Extremely poorly differentiated, vague cell type, prominent nucleoli, vesicular nuclei. Something else which was a little different and was catching my eye. There was multinucleation. Anybody else can figure out something in this? Any relation of these tumor cells with the other cells that you see? With lymphocytes, with RBCs maybe? Sorry? They look RS-like at many places. Some of them are like binucleated. I don't know if I can show you. Yeah. So this. But do you see something happening here? Here? Something wasn't, so there was something that, was catching my eye. Something here. So there's a lot of inflammation around, sorry? So let's see what the markers stained. So this was very vaguely positive for CD45. This was my CD68 and CD4. This was my HLA-DR and CD163. And this was my BRAF V600E IHC. These cells were negative for CK, Desmin, SMA, S100, SOX10. We did a CD30 ma'am because of, to rule out any hematolymphoid in this. ALCL, maybe Hodgkin's, HMB45 because it had prominent nucleoli, CD21, 23, for something pertaining to dendritic cells, MPO117, 20, PAX5 and CD3. So I think, the IHCs were a giveaway. Anybody with the diagnosis? CD1A was, I think it was negative in this case. Yeah, I agree with you. I think I must have skipped, writing it. A high Ki67 index, this morphology, BRAF, HLA-DR, CD68, 163, 45 focal positive. Sorry? No. So yeah, and it was clinically a malignant tumor. Yeah, it's maybe yeah. So I think this was. I can't show you in high power, ma'am, here, but many of the large cells were positive. Yeah. I agree with you. So that's why we had a very descriptive run of hematolymphoid markers on this, and nothing really came positive. Yeah. Correct. So with that in mind, the diagnosis I finally made was of a pulmonary histiocytic sarcoma. Very few cases of it's not a very common case that you encounter, but yes, I had to, speak to the clinician. No, we did the molecular testing on this and right. Yeah. Right. Right. Yeah. Yeah, that's a good thought. So, that's definitely something that can be done in this. So with that, my final case, and I think this was probably the most challenging case for me. This was a 30-year-old male patient who presented with on and off bleeding from the nose, cough with dyspnea along with weight loss. There were dermal nodules in the skin and the patient complained of itching. And in radiology, there were multiple lung nodules. The largest told to me was 2 into 2 centimeters. We did not see the radiology because this came from, an international center. When I saw the slides, something that definitely stood out, I don't know if you can see it clearly, is, there is a lot of fibrinoid necrosis and there is an angiocentric pattern to these cells. I don't know if you can see, that I can see it very well here. And if you see some of these cells, they are very large, right? And the others are more mononucleate. So I forgot to tell you that somebody on morphology had called it Hodgkin's lymphoma, probably, which is not a very bad diagnosis to make. There is, a sort of polymorphous population of lymphoid cells and plasma cells in the background, just that doesn't look like a mixed cellularity subtype for sure. Again, I've put this picture because the necrosis really stands out in this case, if you see. And there are these large cells in the background of a more uniform population. The patient wasn't clinically behaving like a Hodgkin's at all. There were no nodes in this case. And there were these dermal nodules. There was this on and off, itching, epistaxis. So, everybody was confused. What exactly are we dealing with? We did run an array of markers in this. And I will first show you what really came. So what came positive was that the large cells were positive for CD20 and PAX5. Okay. The background cells were positive for CD3. The large cells were also positive for Eber-Risch. So in a nutshell, we had, all the other lineage specific markers were negative. And we had large cells which were positive for CD45, 20, PAX5 and Eber-Risch in a background of, a uniform T cell population which did not show any loss of pan T cell markers, and Eberish was strongly positive. The patient wasn't clinically looking like a lymphoma, and I told you the vague findings clinically that the patient had. So anybody, any idea with the diagnosis here? Sorry? HIV status was negative. Yeah. No, there were multiple dermal nodules. Patient had itching, on and off epistaxis. Sorry? No. Yeah. So like my first thing like that strikes me was I knew that I'm dealing with something which is lymphoproliferative in nature, and which doesn't exactly look like a lymphoma. It has been diagnosed, not really convincing, and it shows some vague systemic symptoms like these. There are a few, nodes were not very prominent, like some centrometric nodes here and there were present, and it primarily involved the lung. Yeah, yeah. No. Please, so I'll just tell you the history. Radiology shows multiple lung nodules, largest measuring 2 into 2 centimeters. So this is an extranodal lymphoproliferative lesion, wherein there are large cells positive for CD20 and PAX5 and Eberish, and a background monotonous population of T cells. So after all that I could read, there is only one diagnosis that I could make. We've shown a lot of, Firangi detectives. I thought I'll show one of our own.
We have less than 5 minutes left.
Yeah, so I think I'll just, I think this should be my last case. Yeah. So, anybody with the diagnosis here? So that's exactly what we called it. This was an EBV-associated lymphoproliferative disorder. And finally, I gave a diagnosis of lymphomatoid granulomatosis. You see, this was a very, very typical morphology. There was angiocentric angiodestructive lymphoproliferative disease. There are findings which are necessary for diagnosis and should always be present. There should be a mixed mononuclear cell infiltrate containing large and small lymphoid cells. The large cells are usually positive. So, this was usually earlier known as probably a T cell neoplasm. But later they realized that this is actually an EBV-associated B cell disorder. And the T cells are the benign, background onlookers in this case. So these should be positive for Eberish. There are graded, less than 50 per high, less than 5 per high power field, 5 to 50, and more than 50 per high power field. So that's how they are graded from grade 1 to 2 to 3. There are some supportive findings which are usually but not always present, like necrosis of the cellular infiltrate, positive ISH for Eber, and multiple lung nodules radiologically. I thought this was a classic case. I actually was trying to read if this was syndromic, and I could actually come across, a background of Wiskott-Aldrich syndrome, which is usually sometimes seen in these cases and could present with dermal nodules, itching, and things like that, but we lost the case to follow up. So, this was something that I wrote and was published in ET Health World. So, the idea of taking this, this talk today was to reinstate the fact that the pathologists as we are of today, our role is way beyond the diagnosis that we make on the slide. Our role goes right to the level of telling what targetable mutations are present, what targetable drugs should be used, whether PDL1 is positive or not, whether immunotherapy would be effective or not. We are as much a part of clinical decision making as clinicians, though we might be the cooks and the chefs in a restaurant who are not always seen, but it's that sumptuous meal, we have a very, very big role to play. With that, I would just like to share some memories of various places, and this is my team in SRL Bombay. And with that, I would like to conclude my session. Thank you so much.